Hi, my name is Janet Anderson, and I'm Assistant Professor of Pediatric Emergency Medicine at Mayo Clinic, Rochester. My colleagues and I would like to present to you Codeine Dispensing among Pediatric ED patients 2010 to 2019. We have no financial disclosures or conflicts of interest. Codeine, or 3-methylmorphine, is a prodrug that has to undergo metabolism to reach analgesia, majority of which goes through glucuronidation, but there are two cytochrome P450 mechanisms for metabolism of codeine. The first of which is the 3A4 system, and the most important one is the 2D6 enzyme. The cytochrome P450 2D6 allele has a vast amount of polymorphism, which in the extensive or normal metabolizer, codeine will only be converted to 5 to 10% of morphine, where the ultra rapid metabolizer will produce 50 to 75% more morphine than the extensive metabolizer. This results in vastly different amounts of morphine produced in children and has resulted in significant morbidity and mortality in children. In addition to the allelic differences in metabolism, there's also special populations in children that seem to be more sensitive to opioids, particularly the children status post tonsillectomy and children with obstructive sleep apnea. This has led to progressive warnings against codeine, first of which was from the WHO, who in 2011 took codeine off the central list of medications for children. Then subsequent FDA recommendations, first with status post tonsillectomy and adenoidectomy in children, and then less than 12 years for any indication, and then for less than 18 for cough. Recently, there was a publication that showed an increasing trend of codeine among adolescents and young adults. This study particularly used the NHAMSIS database, which actually uses visit level data rather than patient level data to come up with these estimates. So our study question was, are codeine prescriptions really increasing despite progressive warnings from the FDA, mounting science about metabolism variation, and better analgesic alternatives for children? Our study design was an observational study using claims data from the Optum Labs data warehouse. Optum Labs combines administrative, clinical, and links them together into a platform. It contains over 19% of commercially insured Americans. In addition, it contains a proportion of the US estimate of patients and a geographic diverse population that emulates the US. So in this database, we looked at all children less than 18 years from 2010 to 2019 that had a codeine or opioid containing cough prescription within 3 days emergency department visit. In this 10-year period, we had over 23 million person years of coverage. Examining the children less than 12 years of age for analgesia, there was a decrease of 96% from 511 to 18 per 100,000 person years of coverage. If we look at this rate of 18 per 100,000 person years of coverage and the US population of children less than 12 in 2019, which was 48.4 million, and if the rate of children prescriptions for commercial children would be similar to other insured children, that would equate to approximately 8,600 prescriptions in 2019. Looking at codeine for cough in the less than 12-year-old child, the rate decreased approximately 95% from 53 to 3 per 100,000 person years of coverage. Similarly, if we look at the population, this would equate to approximately 1,452 prescriptions in 2019. If we look at the overall trend, it has been a steady decrease. And at 2011 and 2017 were when the recommendations were made for the less than 12-year-olds. Codeine for cough in the 12 to 18-year group decreased 78% from 66 to 14 per 100,000 person years of coverage. Looking at this specific population, there was approximately 24.6 million of them in 2019. If this rate of commercially insured children is similar to all children, That would equate to approximately 3,444 prescriptions throughout the United States in 2019. Looking at other opioid cough preparations, that rate decreased approximately 98% from 14 to less than 1 per 100,000 person years coverage. The overall decline has been steady, but there was a peak in 2012. So in conclusion, there has been significant decline in the ED-associated codeine prescriptions for cough and analgesia in children and adolescents since 2010. Though there was a peak in 2010 for codeine in adolescents, the trend has steadily declined. Currently, the rates are low, but continue despite being contraindicated and restricted in children. Thank you for listening to our presentation, and we are happy to take questions.
Hi, my name is Bailey Lott. I'm here today to talk about our study, Reducing Time to Resolution of Pediatric Diabetic Ketoacidosis. Does it help to start insulin early? We are going to review the background behind the study, how we performed the study, what we found, and how we can implement the results. I have no disclosures. The study was born out of a QI project with the aim to lower our time from ED arrival to regular insulin infusion, and the thought that this would improve time to resolution. As we studied the past data, we realized that, although this project has been going on for years, there was minimal to no improvement in time to resolution seen. When reviewing past studies, we were unable to find a previous study examining an association between time to insulin and DKA resolution. The more we pondered the disease process, the more questions arose to the utility of the goal of prioritizing early insulin. First, there is a question of the safety of early insulin. Studies have shown that early insulin within the first hour of therapy has been associated with cerebral edema. This is reflected in the ISPAD guidelines. Secondly, as you get into the more theoretical question of the pathophysiology of diabetes, you run into a phenomenon of the stress hormone response causing insulin resistance associated with DKA. This raises the question of whether or not early insulin will even be effective. High counterregulatory hormones in this state increase lipolysis and ketogenesis, leading to ketonemia and metabolic acidosis. The dehydration caused by the osmotic diuresis stimulates stress hormone production, inducing insulin resistance and creating a vicious cycle. Overall, though, our primary hypothesis was still that a shorter time from presentation to regular insulin infusion would be associated with a shorter time to resolution in DKA. Secondary measures were chosen based upon possible confounding factors we thought could affect time to resolution. Severity and PICU go hand in hand. We thought logically the more severe the acidosis, the longer the time to resolution. Maximum chloride and cerebral edema treatment are also tied together due to the fact that at our institution, we generally treat suspected cerebral edema with 3% saline. That, along with hyperchloremia from standard treatment, can lead to hyperchloremic metabolic acidosis, which will play a factor as we are basing resolution off of correction of acidosis. Acute kidney injury, new onset disease, and associated infections were also examined. This was designed as a retrospective review of patients aged 1 to 18 years from 2017 to 2019 that presented to our pediatric ED. Patients that were transferred and those treated off protocol were excluded. We defined time to insulin as arrival to start of a regular insulin infusion, and time to resolution as time from initial resuscitation, which would be a normal saline bolus based upon our protocol, to the first measurement of a bicarbonate of 16 or greater. Statistical analysis was performed as indicated. 328 patients presented in DKA and 176 met criteria for inclusion. 36% of patients were mild, 44% were moderate, 20% were severe, and the median age of patients was 14, with an overwhelming majority being type 1. A small portion of patients had altered mental status, which was defined as the need for treatment with hypersaline or mannitol. And AKI was defined based upon stages of GFR. Statistical analysis showed that GFR, new onset diabetes, and patients with associated infections were not associated with time to resolution of DKA. Analysis showed that potentially confounding variables included initial and final measured bicarbonates, admission to the ICU, altered mental status or treatment with hyperosmolar therapy, and the patient's peak chloride level. When controlling for these confounding variables, we found no statistically significant association between time to insulin and time to resolution in DKA. Limitations of this study include the retrospective nature, which makes it difficult to control for confounding variables. One particular variable of importance includes the bicarbonate, that is the cornerstone of gauging severity in resolution of DKA. Unfortunately, there is no way to measure this in continuous fashion, making the ability to pin down the exact time of resolution difficult, to say the least. Also, in relation to treatment, there was a variable rate of insulin infusions, especially in relation to our PICU patients. While it would be nice to control for this, a number of studies have shown no difference in time to resolution when comparing rates of insulin infusions. So, based upon past data, this should not affect our results. Current DKA literature seems to be trending towards a focus of increased fluid resuscitation in the initial treatment of pediatric DKA. While our study does not focus on fluids, it still lends support to this trend. I speak with a lot of ED physicians that feel that by not giving DKA patients insulin during their initial treatment, we are not really treating them and are hampering their ability to recover. While these patients do need insulin during treatment, the study offers reassurance that if we make the choice on certain patients to delay insulin, possibly, for example, to further fluid resuscitation, we are not delaying, hampering, or preventing recovery from DKA in our pediatric patients. Other areas that we see these results being applied includes the transport world. Insulin drips require frequent glucose monitoring and fluid and dextrose changes, which can be difficult during transport. The results open up the possibility of the cost and safety benefits of being able to transport off insulin while continuing treatment with fluids, which can be studied further. I want to thank you all for listening, and I'm happy to answer any questions during the question session or by email. Thank you again.
Hi, my name is Sarah Margolius. I'm a Pediatric Emergency Medicine Fellow at Rainbow Babies and Children's. The title of my talk today is Comparing Pediatric Opioid Prescribing Practices from Pediatric versus General Emergency Departments. I have nothing to disclose. In terms of background for my project, opioid prescribing rates for pediatric patients discharged from emergency departments has decreased recently. We also know that pediatric patients are more likely to receive an opioid prescription from a general ED rather than from a pediatric ED. In terms of the diagnoses that are receiving opioid prescriptions, a study done within pediatric emergency departments and urgent cares showed that pediatric patients with non-injury diagnoses received a longer prescription for opioids. Specifically here in Ohio, there was legislation passed regarding the prescribing of opioids back in 2012, which limited emergency and acute care opioid prescriptions to a 3-day supply for acute pain. The objective of this study was to describe opioid prescribing practices for pediatric patients at discharge from both a pediatric ED and 12 general EDs within a hospital system in Northeast Ohio. We did a retrospective cohort study. We included pediatric patients ages 18 years and younger who were discharged from a pediatric ED or 12 general EDs with an opioid prescription over the course of 1 year in 2018. We did exclude patients who received opioid prescriptions for chronic pain, for example, palliative care or sickle cell patients, as these chronic pain patients were not included in the Ohio 2012 guidelines regarding opioid prescriptions. We collected demographic information, information about the encounter, including the date, location, and the discharge diagnosis that was associated with the opioid prescription. We then characterized the discharge diagnoses into injury and non-injury diagnoses. Injury diagnoses included things like fractures or burns, for example, whereas non-injury diagnoses were considered to be things like headaches, abdominal pain, oral pain, for example. We also looked into the type of opioid that was prescribed as well as the length of prescription, and then ran descriptive statistics. And here are our results. So we had a total of 361 pediatric patients who received opioid prescriptions during our 1-year study period. 59.6% of patients were discharged from a general ED. Overall, here in red, you can see pediatric patients received an opioid prescription more frequently for an injury diagnosis at 68.7% compared to a non-injury diagnosis. Between general EDs and pediatric EDs, there was a statistically significant difference between opioid prescriptions in terms of injury diagnoses. 87% of opioid prescriptions from the pediatric ED, seen in blue here, were for injury diagnoses as compared to 56.3% of prescriptions from general EDs. In terms of the types of opioids prescribed from the general and pediatric EDs, the pediatric ED here on the right almost solely prescribed oxycodone, about 98%, whereas you can see on the left a wider variety of opioids were prescribed from the general EDs. Almost 50% of the opioids prescribed from the general EDs were combination opioids, such as oxycodone acetaminophen, hydrocodone acetaminophen, and codeine acetaminophen. We also found that the pediatric ED prescribed a shorter duration of opioid for both injury and non-injury diagnoses as compared to the general EDs. For injury diagnoses, the pediatric ED prescribed a median of 1.67 days length of prescription here in red versus 3 days from the general ED. For non-injury diagnoses, the pediatric ED here in blue prescribed a median of 2 days length of prescription versus 3 days from the general ED, and these differences were statistically significant. We also looked at the discharge diagnoses that received opioid prescriptions. Fracture was the discharge diagnosis that received the majority of opioid prescriptions from both the general EDs and the pediatric ED. For non-injury diagnoses, the general EDs prescribed opioids for abdominal pain, oral pain, ear pain, headache, and abscess more frequently than the pediatric ED. In conclusion, we found general EDs prescribed a wider variety of opioids for pediatric patients, whereas the pediatric ED almost exclusively prescribed oxycodone. One possible reason that the pediatric ED prescribes only oxycodone and doesn't prescribe things like combination opioids is perhaps that pediatric physicians are more likely to want to titrate opioid and non-opioid medications such as acetaminophen or NSAIDs in order to optimize pain control. We also found that pediatric patients received a shorter duration of opioid prescription for both injury and non-injury diagnoses from the pediatric ED as compared to the general EDs, which could be perhaps because general EDs see adult patients along with pediatric patients and may have a higher set point for prescribing opioids, which could trickle down to pediatric patients in that setting. Here are my references, and thank you very much for your time.
Hi, my name is Kathleen Costello, and I'm a Pediatric Emergency Medicine Fellow at Dell Children's Medical Center in Austin, Texas, and I'll be presenting on our project Screening for Human Trafficking in the Pediatric Emergency Department, a pre- and post-intervention study. There are no financial conflicts of interest to disclose. Child sex trafficking is defined when a minor is engaged in a sex act for something of perceived value. Coercion, fraud, and/or force are not required to meet the definition, and those under 18 years old. Different forms include pornography, survival sex, sex tourism, and mail order. In Texas alone, there are approximately 79,000 minor and youth victims of sex trafficking. 85% of victims of sex trafficking in the US are US citizens, and 55% are minors. Studies suggest 90% have contact with healthcare providers during their exploitation, and about 63% specifically visit the emergency department. Previous studies utilizing the screener have focused on high-risk chief complaints to determine who is screened in the ER. These include outcries, assault, GU complaints, and behavioral health complaints. In our study, we applied a 6-question screening tool that was previously validated and administered it universally to ages 12 to 17 years old. The form was administered in both Spanish and English. Exclusions were refusal to answer the questions, moderate to severe developmental delay, altered mental status, severe pain or critical condition, or those who cannot answer the questionnaire independently. Positive screens received a social work consult, and cases concerning for human trafficking received a referral to the Human Trafficking Task Force. If a referral was placed, the patient was defined as a positive case. Positive cases were compared to previous referrals to the Human Trafficking Task Force during the same time period in the 2 years prior to the study. Table 1 demonstrates our demographic data. Our average age is consistent with national averages. Studies suggest many adult victims were initially trafficked around the age of 15 years old. We did successfully identify male victims, which is acknowledged as a significant challenge when screening for child sex trafficking. Race and insurance data did not suggest significant differences. Table 2 breaks down the chief complaints seen based on suspected victim status. Chief complaints noted in victims included runaway, assault, sexual assault, behavioral health complaints, POED, and drug use. Interestingly, we also had victims present with solo chief complaints of vomiting, high blood sugar, abdominal pain, or basic social service needs. Trauma showed no victims, but it's important to note that non-accidental trauma, sexual assault, and assault were categorized under psychosocial unless traumatic injury was included in the chief complaint, and then it would be categorized in both. The most significant chief complaint difference was seen between the two groups with psychosocial. The rate of suspected victims of child sex trafficking identified over the study time period in 2018 and 2019 was 2.43 per 1,000 visits in children ages 12 to 17. The rate of suspected victims identified while using the screener was 6.51 per 1,000 visits, with a significant difference noted. Key points from our study: universal screening is feasible and may improve identification of child sex trafficking while eliminating potential bias. Additional benefits include identifying high-risk behaviors in adolescents, including drug use, early onset sexual activity, multiple partners, domestic violence, and potential gang involvement. There were no parental complaints regarding the screener. Limitations included the limited time period of the study. This was due to the COVID-19 pandemic when screening was paused at the initial 3 months. There were a limited number of positive cases. Identifying true cases of child sex trafficking remains difficult, as investigations often take years if completed. Patient readiness to share information and variations in execution of the screener. Future studies could focus on a larger trial of universal screening and long-term follow-up and integration of recovery programs. Here are some references for your use.
Hello, my name is Elise Perlman, and today I'm going to be talking about our paper called Changes in Pediatric Emergency Department Presentations During the COVID-19 Pandemic in New York City. We have no disclosures. New York City became the epicenter of the COVID-19 pandemic during the spring of 2020. There has since been a significant reduction in pediatric emergency department visits. We've all been asking ourselves, what happened? Where did our patients go? In this study, we aim to describe the specific changes in pediatric presentations to further inform our understanding of pediatric healthcare utilization during this time and prospectively. While the absolute number of patient presentations decreased, we hypothesized that there will be a proportional increase in acuity as measured by ESI levels, admission rate, and admission location, and that there will be a proportional decrease in visits of infants and children. This is a retrospective observational study performed at 3 affiliated hospitals in New York. We looked at patients aged 0 to 18 presenting between December 2018 and August 2019, compared to December 2019 and August 2020. Overall, there was a 27% decline in presentations between the 2 time intervals. Using monthly proportions, we were able to account for this decline and demonstrate how exactly the composition of the smaller patient population changed. We were interested looking specifically at months March through May, with a focus on April corresponding to the peak of the pandemic in New York. We compared monthly proportions of visits by age, gender, and other demographics, including insurance, preferred language, and self-described race. We also compared proportional changes of ESI levels, admission rates, and admission locations as surrogate markers to assess for changes in degree of acuity. We also looked at ED mean length of stay. When compared to the year prior, the overall number of ED visits began to decrease in March, reaching a nadir in April, followed by a gradual increase thereafter, but never reaching back to pre-COVID levels. Visits in April most dramatically decreased by 82%, or in other words, visits in April reached a mere 18% of what they were the year prior. Looking at the proportional changes in April, ESI levels 1 to 3 increased by 10.5%, hospital admissions increased by 10.8%, with a 5.5 and a 1.9% increase in PICU and OR admissions respectively, while the proportion of patients less than 1 year of age increased by 7.6%, those aged 1 to 14 decreased by 11, and aged 15 to 18 increased by 3.3%. Statistical significance is indicated by the star. There were no differences in presentations by race, language, or insurance status, and no difference in mean ED length of stay. Our aim of the study was to identify possible trends in pediatric ED presentations during the pandemic. So what happened to our volume? We demonstrated, as we just saw, a significant decline in the overall number of presentations during the pandemic. This reduction coincides with the rise of COVID cases in New York. In early March, there were only 80 total cases. This increased exponentially to over 150,000 total cases by the end of April. It also coincides with the governor's New York on pause order, strict social distancing measures, followed by the expansion of telemedicine operations to divert patients from the ED as offices were starting to close. We experienced fewer ED visits, but those that did present were of greater acuity. While we don't know the answers, we ask ourselves whether this could be due to possible delays in care and presentations, followed by disease progression. We also saw significantly greater proportions of patients less than 1. There are several reasons that could account for this. Infants less than 1 are at higher risk for severe illness, and even with the rise of virtual urgent care, they would be difficult to examine virtually, and those with fever 24 to 48 hours are encouraged and recommended to be seen by a physician. And with most offices being closed, the emergency department was the only resource available for in-person care. We found a significant decrease in the proportion of patients 1 to 14. When we ask why, it's possible that there were just fewer emergencies. Closure of schools and parks would lead to an obvious decline in the transmission of communicable diseases, fewer opportunities for outdoor orthopedic injuries and lacerations, and parents were now working remotely from home. They were newly able to watch and wait for symptom resolution before rushing to the emergency department. Overall, there are fewer emergencies and therefore fewer visits. This is a retrospective study of an electronic medical record system, and therefore missing data prevented the analysis of surrogates of poverty, crowded living conditions, lack of insurance, and access to medical care. We were unable to demonstrate the reason for decreased visits, specifically whether it was fear of COVID, lack of transportation, public announcements. We can only speculate. So what now? Where do we go from here? Despite the plateau of COVID-19 cases, the reopening of businesses, restaurants, resumption of sporting activities, the number of pediatric emergency department visits have not yet returned to baseline. We ask ourselves, has access to healthcare changed such that we are no longer needed the way we once were? Is there a trend towards this watch and wait mentality? Is the future in virtual visits? And if this is the case, will those with medical or surgical emergencies present appropriately, or will there be delays in care? As providers, we have an obligation to advocate and educate our patient populations on resource utilization and also to ensure appropriate access to healthcare, whether that's urgent or emergent, and to do our best to make sure we're not missing folks that require medical attention. Finally, it is also important to consider the impact of reduced patient volumes on the medical education of our trainees so that we can plan for alternative methods of teaching during this time and prospectively. Thank you all very much for listening, and I hope you all enjoy the rest of your days.
Hello, my name is David Greenkey, and I'm a fellow in Pediatric Emergency Medicine at Emory University in Atlanta, Georgia. This project is looking at the effectiveness of the Triage travel screen to detect travel-related illness in the Pediatric Emergency Department. I'd like to recognize and thank my multidisciplinary team, especially my mentor, Dr. Brittany Murray. We have members from the Pediatric ED, Adult ED, Infectious Disease, and Statistics departments at Emory University. The ED Triage travel screen was implemented in the United States in 2014 at the recommendation of the CDC during the Ebola outbreak. While it was initially intended to screen for Ebola, it is now used as a de facto screen for all travel-related illness. The ED travel screen was recommended as part of CDC's Identify, Isolate, and Inform strategy for travel-related illness, but it was not meant to replace a provider-taken travel history. However, in many instances, it may be used incorrectly, essentially replacing a provider-taken travel history. We intend to investigate the efficacy of the ED Triage travel screen. The early stages of the COVID-19 pandemic reminds us how important it is to screen for travel-related illness. As travel now opens back up, we want to know how to identify patients at risk for travel-borne illness. The aim of this project is to understand the efficacy of the ED travel screen to detect travel-related illness in emergency departments at Children's Healthcare of Atlanta in Atlanta, Georgia. These 3 EDs see the majority of children that present for emergency care in metro and surrounding areas of Atlanta, Georgia. Atlanta is also home to the busiest airport in the world and a rich community of of immigrants and refugees, making it an ideal location to study the travel screen. This was a retrospective cohort study of ED encounters across 3 CHOA EDs in 2019, completed through review of electronic medical records. The ED triage travel screen asked, has the child or a close contact of the child traveled outside the United States in the past 21 days? The incidence of malaria, dengue, and typhoid were compared between patients with positive and negative travel screens and screens with no response. These 3 diagnoses were chosen because they are nearly certain to be travel-related diagnoses in the United States. A chart review is then completed for patients with these diagnoses to get more details on the travel screen and provider-taken travel history for those encounters. There were 244,841 ED encounters in 2019. The mean patient age was 4.91 years. 116,563 were female, 3,352 of the encounters had positive travel screens, and for 5,185 encounters, no response was recorded. There were a total of 7 cases of malaria, 1 of dengue, and 5 of typhoid. Many of these cases were correlated with a positive travel screen at their initial ED presentation. However, this did not always lead to the travel-related diagnosis that was present. Looking at the chart from left to right, for the 7 malaria cases, 6 had positive travel screens at the initial visit, but only 5 of 7 were diagnosed at the initial visit. The 2 that were missed had no documented travel history at the initial visit. For the 1 case of dengue, it had a positive travel screen and was diagnosed at the initial visit. For the 5 cases of typhoid, 3 of 5 had positive travel screens at the initial visit, and 3 of 5 were diagnosed at the initial visit. The 2 that were missed had no documented travel history at the initial visit. In 1/3, or 4 of 13 of the travel-related diagnoses in 2019, there was no travel history documented in the initial ED visit after travel. All of these encounters led to repeat ED visits where the travel-related illness was then diagnosed. Our study brings up some important conclusions. First, there was a positive travel screen for most of the encounters with travel-related diagnoses. However, this did not always lead to the recognition of the travel-related diagnosis. Second, the ED triage travel screen does not replace a provider-taken travel history, which continues to be very important when working up patients for travel-related illness. In our study, all of the missed diagnoses had no recorded provider-taken travel history. Finally, in our study, there were more no responses to the travel screen than positive screens. Improvements to the ED triage travel screen that increased both screen compliance and correlation with the diagnosis of travel-related illness should be studied.
Hello, my name is Nicole McCullum. I'm a second-year pediatric emergency medicine fellow at Children's National Hospital in Washington, D.C. I'm presenting data collected as part of my primary fellows research project on consent documentation for procedural sedation in the emergency department. This is one piece of my global project to enhance the consent process for all procedures in our emergency department, focusing on the 2 most common we consent for, pediatric procedural sedation as well as lumbar puncture. There's general consensus that the key elements in informed consent for procedures should include the procedure to be performed, benefits, risks, alternatives, and signatures of both the provider as well as the person providing consent. The objectives of this study are to evaluate the completeness of the written consent documentation for procedural sedation in the pediatric emergency department and to determine the association with provider level of training. A secondary objective is to evaluate the frequency that a Spanish language consent form is used for patient encounters requiring a Spanish language interpreter. We performed a retrospective review of written consent documentation over a 3-year period. Charts were identified by procedural sedation billing code, as well as ketamine medication administration, as ketamine is by far the most common medication we give for procedural sedation in our emergency department. 1/3 of the encounters were selected at random. Charts were excluded if the consent form was missing or the consent was not obtained by an ED provider. Consent documentation was reviewed for elements included on the form and the provider level of training. The medical record was also reviewed for the use of a Spanish language interpreter during any point of the encounter. Just over 2,100 encounters were identified by querying the EMR for procedural sedation codes and ketamine administration. 1/3 of them were randomly selected, and of those, 655 met inclusion criteria. The treating provider was a PEM attending for 49% of the encounters. The treating provider was a PEM fellow or an ED-based pediatrician, abbreviated ED-PEDS, for 35% of the encounters, and a resident was the only provider on the consent form in 11% of the encounters we looked at. Advanced practice practitioners, PAs and NPs were excluded from analysis due to small sample size. Graphically displayed here are the frequency that the consent elements were included. Listed on the top portion of the y-axis are the benefits, followed by the risk in the middle portion, and then finally the alternatives in the lower third of the chart. The gray bar represents all encounters, the red bar PEM attendings, and the blue bar PEM fellows and ED-based pediatricians. The odd ratios and 95% confidence intervals comparing PEM fellows and ED-based pediatricians to PEM attendings is to the right of the bars. The most commonly documented benefits for all encounters were pain control and the ability to complete the procedure. Notably, the ability to complete the procedure was less likely to be included by PEM fellows and ED-based pediatricians compared to PEM attendings with an odds ratio of 0.8. The most commonly included risks were nausea or vomiting and breathing problems. Agitation or emergency reaction was more likely to be discussed or included on the consent form, I should say, by PEM fellows and ED-based pediatricians when compared to PEM attendings with an odds ratio of 1.8. For most elements, PEM fellows and ED-based pediatricians were more likely to document compared to PEM attendings. Of the 655 encounters reviewed, a Spanish language interpreter was required for 13% of those. And of those, a Spanish language consent form was used for 80% of those patients. Overall, PEM attendings are less likely than PEM fellows and ED-based pediatricians to document elements of consent. Based on these findings, we are planning future investigations of whether or not a standardized pre-completed written consent form could improve documentation and decrease variability across provider type.
Good morning. My name is Madhuri Deve, and I'm a second-year Pediatric Emergency Medicine Fellow at Indiana University. It's an honor to present my fellowship research project at the SAEM virtual conference this year. My project investigated risk factors for prolonged procedural intravenous ketamine sedation in the pediatric emergency department. I have no personal disclosures to report. Ketamine has been found to be a safe and effective choice for sedation, which has been increasingly used for bedside procedures in the pediatric emergency department. Current professional guidelines recommend each institution to determine the maximum length of sedation performed in their ED, resulting in a lack of uniform definition. To date, prolonged IV ketamine sedation in pediatric EDs, including the associated complications and department operational implications, remain undefined in literature. Identifying factors that lead to prolonged sedation is important when making decisions for alternate sedation plans when necessary. So why do we care? I'm sure many of you have been in sedations that have lasted longer than anticipated and may have had a couple of thoughts running through your mind. How much longer can I keep my patients sedated safely? Or, I wonder how many patients are now roomed and are waiting to be seen. Anecdotally, we have observed an increase in the number of prolonged sedations and wanted to identify objective data that would help guide our decision for providing sedations, while also considering patient safety and overall departmental flow. At our institution, prolonged sedation is defined as lasting greater than 30 minutes. Sedation time was calculated from the time the first ketamine dose was given to the time the physician leaves the bedside. The primary aim of this study was to identify risk factors leading to prolonged sedation, while the secondary aim was to determine complications, and if present, were there any differences between the two groups. We performed a retrospective chart review at a quaternary care freestanding pediatric hospital. Subjects were those between the ages of 1 through 18 who received procedural sedation with IV ketamine. No exclusions were made. A total of 486 charts have been reviewed to date. If identified as receiving IV ketamine, charts were abstracted for those data points listed and were recorded on a standard data collection form. In addition to minor complications such as emesis, serious adverse events and significant interventions were recorded. Our results found that 35.1% of all sedations were prolonged, with an average sedation time of 24 minutes. Prolonged sedations correlated with laceration repairs and orthopedic reductions. Gender, race, ethnicity, and age were evaluated and found to have no statistical association with prolonged sedations. Of the sedations completed, we found that oral maxillofacial surgery was 3 times more likely to have prolonged sedations when compared to those who routinely perform more minor procedures. This category was recorded as other, which included pen physicians, ophthalmology, and urology. 54% of procedures completed by OMFS were found to be prolonged. Orthopedic surgery was 2 times more likely to require prolonged sedation, with 39.3% of orthopedic procedures requiring longer sedation times. Laceration length was found to be a statistically significant risk factor. Lacerations 4 centimeters and above were noted to have longer sedation times. Additionally, 46% of facial laceration repairs were found to have prolonged sedations. No serious complications were found in this cohort population. 2 patients were noted to have a minor complication of emesis. Of note, analysis of prophylactic measures found that 55% of prolonged sedations received IV Zofran and 76% of patients were started on 2 liters nasal cannula prior to the start of the sedation. And lastly, there was no statistically significant differences in the length of stay in those patients who required longer sedation time. In the current cohort at this institution, the subspecialty performing the procedure and laceration length were associated with longer sedation times. Interestingly, minimal complications were noted in this cohort. However, departmental prophylactic measures may have contributed to the decrease in the number of adverse events found. Ongoing data collection is underway as we extend to 2019 sedations. We are currently data gathering to further delineate and specify orthopedic procedures and injuries, as well as analyzing department-wide length of stay to help guide decisions for alternate sedation plans when considering overall ED operations. Thank you very much.
Thank you for having me today. I'm a third-year pediatric emergency medicine fellow at Ann and Robert H. Lurie Children's Hospital of Chicago, and I'll be presenting my project today entitled Factors Associated with 3-Day Revisits to the Pediatric Emergency Departments. 3 to 5% of pediatric emergency department encounters represent 3-day revisits. 3-day metric is commonly used with implications for quality improvement and reimbursement in pediatric literature. Previous studies have been largely single-center, utilized data prior to Medicaid and telehealth expansion, and did not include diagnoses in their predictive model. We know that improved identification of risk factors for revisits may facilitate predictive modeling and improve the quality of care while minimizing burden to the healthcare system. Our objectives were twofold: to characterize revisits to the pediatric ED within 3 days of their index visit, and to identify predictors of those revisits within 3 days, and specifically medically necessary revisits in this population. In order to do this, we performed a retrospective multi-center cohort study of the FIS database. The FIS database is a billing database that includes greater than 50 children's hospitals in the US. We included patients 0 to 18 years of age discharged from the pediatric ED from January 1st to December 31st, 2019. The time period that included the COVID-19 pandemic in the United States was excluded due to rapid and sometimes temporary expansion of telehealth services. We excluded all interfacility transfers. Our primary outcome of interest was revisits to the same pediatric ED within 3 days of the index visit. Our secondary outcome was a medically necessary revisit within 3 days, defined as the authors as hospitalization with length of stay greater than 1 day, operating room charge, ICU charge, admission with supplemental oxygen, or in-hospital mortality. We collected patient level and visit level factors as listed here. Of note, complex chronic conditions were defined based on an established classification scheme that has been widely used in pediatric health services literature. Descriptive statistics were used to describe outcomes and variables of interest. Univariable and multivariable logistic regression was performed to identify factors associated with each outcome. We performed a sensitivity analysis that included unique patients only, randomly selecting a single encounter per patient for patients having multiple encounters during the time period, and considering each hospital site as a random effect. Lastly, we fit a random forest model to investigate relative variable importance associated with each outcome. Of the 2.7 million encounters that were included, 4.3% were classified as 3-day revisits. Of those, 19.5% met our criteria for medically necessary revisits. The majority of patients were between 1 to 12 years of age and had public health insurance. The most common diagnostic categories were general medical, gastrointestinal, respiratory, and trauma. Chronic conditions were present in 4.5% of all encounters, but more common among revisits. When comparing diagnoses among index visits and revisits, respiratory diagnoses constituted the largest proportion of patients' subsequent visits, with a decrease noted in proportion of patients with a general medical diagnosis. The time to revisit was pretty equally distributed across 0 to 3 days. Among revisits, circa 1/5 were assigned the same principal diagnosis as their index visit. Very few revisits required admission greater than 1 day, admission to the ICU, procedures in the operating room, supplemental oxygen, or resulted in mortality. Our multivariable logistic regression analysis identified multiple factors associated with revisits. I will highlight a few of the variables with the largest effect sizes. First, age greater than 1 year was associated with the lower adjusted odds ratio of revisits. A higher adjusted odds ratio was identified in encounters with a neoplastic diagnosis, while a lower adjusted odds ratio was identified in encounters with trauma or poisoning diagnoses. In a multivariable analysis for medically necessary return visits, we observed similar findings with respect to our primary outcome, with some exceptions. For example, having public health insurance was positively associated with the revisit, but negatively associated with being medically necessary. On the other hand, behavioral and gastrointestinal diagnoses were negatively associated with revisits, but positively associated with being medically necessary when they did return. When limited to 1.9 million unique patients in the dataset, public payer was no longer a significant predictor. Lastly, we constructed a random forest model to identify variable importance. We found that diagnosis, blood testing at the index visit, age and season of visit were the most important variables in predicting both 3-day revisits and medically necessary revisits. Overall, we found a 4.3% rate of 3-day revisits, which has been stable over the past decade despite improvement efforts. It's important to note that the PHYS database does not yet include data from the COVID-19 pandemic in 2020, which may have unique findings. The strongest positive predictor of pediatric ED revisits with statistical and clinical significance included age less than 1 year, chronic conditions, or neoplastic diagnoses. Given that these are all high-risk groups, this may not be an indicator of quality of care received in the ED, but instead may be related to natural disease progression. We propose that special care ought to be taken with these populations to ensure timely follow-up. Traumatic injuries were noted to be negatively associated with revisit within 3 days, likely due to the self-limiting nature of such injuries. Encounters with public insurance represent a unique finding, as they initially were positively associated with a small effect size, but negatively associated with being medically necessary. The statistical significance attenuated when controlling for patients with multiple encounters, indicating that a smaller cohort with high frequency ED use may be responsible for the initial finding. I'd like to thank all of my mentors and co-authors for their contributions and support. I'm happy to take questions at this time.
Hi, my name is Kaisa. I'm a second-year pediatrics resident at St. Christopher's Hospital for Children in Philadelphia, Pennsylvania. Today, I'll be speaking on a retrospective review of pediatric opioid ingestions and the time to naloxone. This study was done together with Dr. Neha Dadhania, third-year PEM fellow, and Dr. Catherine Burdett, the attending in our department. None of us have any financial disclosures at this time. One of the most common causes of injury to children less than age 6 is the ingestion of harmful substances. They often present to the emergency department where quick and appropriate intervention is vital to reducing associated morbidity and mortality. Outpatient medication use is also becoming increasingly more common in the United States. A recent study showed that 82% of American adults and 56% of children take at least one medication each week in the outpatient setting. This high frequency of medication use and the increasing number of medications stored in American homes increases the chance of medication overdoses, particularly in the pediatric population. Our current opioid epidemic is a growing public health concern nationally and now affects all segments of society, including children and adolescents. In Philadelphia in 2018, there were 8,482 emergency department visits for opioid overdoses, with 5% of those in patients under the age of 19. Unintentional drug overdoses contribute to pretty significant rates of premature mortality in the city, with most overdose deaths involving opioids. We've also seen a large increase in the number of fentanyl involved overdoses as well. In 2019, the highest number of overdose deaths in Philadelphia occurred in the 19134 zip code, indicated on the map by the dark blue area. The red star also indicates the location of our children's hospital. Limited research on pediatric opioid ingestions currently exists, and one of the main sources of research in pediatric ingestions is the National Poison Control Database, although many departments defer to their local toxicology departments, so we may be missing some critically ill data. Historically, pediatric patients have been known to present without classic toxidrome findings on initial physical exam, including opioid ingestions. The primary objective of our study was to assess the presentations of pediatric opioid ingestions and subsequent medical management in an urban level 1 pediatric trauma emergency department in Philadelphia, including the use and timeliness of naloxone administration. We included patients from a 4-year period between October 1st, 2015 and October 1st, 2019, who were diagnosed with an opioid ingestion either by ICD-10 code or based on whether naloxone was ordered while in the emergency department. Of those 453 charts reviewed, 373 were excluded, leaving 80, which we then subsequently split into groups, known ingestions and unknown ingestions. The mean age of patients was 7.4 years for known ingestions and 6.2 years for unknown ingestions. Of note, 52% of all patients presented with constricted pupils. For known ingestions, the time to naloxone administration was 73 minutes. For unknown ingestions, the time was slightly less at 45 minutes. In looking at the demographics of our study, there was no significant difference between gender and race of the study population, and the chief complaints most common during presentation were known opioid ingestion, altered mental status, or difficulty breathing. Of note, in the unknown ingestion category, 73% of patients presented with a chief complaint of altered mental status. In looking at the administration of naloxone, 95% of our study population received naloxone and 51% had a documented response to the medication. While 45% of the patients did receive multiple doses of naloxone, only 8% required continuous infusion of the medication. A large majority of our patients, 80%, did not require supplemental respiratory support in the emergency department. And of the 7 patients who did require intubation, only 5 were in the unknown, 5 of them were in the unknown ingestion category. 6 of our total patients were sent directly home from the emergency department, and the remainder of the study population was fairly evenly split between admission to the inpatient floor versus admission to the ICU for further observation. A urine drug screen was sent for 89% of our study population, and 45% of our study population had a serum drug screen sent. Of the urine drug screens that were sent, 6% returned positive for opioids, 25% were positive for another substance, and 69% were all negative. Of the serum drug screens that were sent, 22% were positive for opioids, 28% were positive for other substances, and 50% were all negative. Of the entire study population, only 36% had a CY47 filed while they were in the emergency department. In conclusion, the time to naloxone for patients with unknown ingestions was faster than those with known ingestions per history. Patients with unknown ingestions required increased respiratory support. Pediatric patients did not consistently present with the classic exam findings of pinpoint pupils. In looking at the future, we do need more information and research with a larger sample size to further investigate the opioid toxidrome presentation in pediatrics. A multi-center study focused on pediatric opioid ingestions would be helpful in comparing national trends, and initiatives to educate pediatric emergency providers may aid in faster diagnosis and more timely administration of naloxone in general. Thank you.
Hi, my name is Becky Berger, and today I will be talking to you about my study of faster CT scanner means fewer sedation for head CT in children. I have no financial disclosures. This was an unfunded study, and it was approved by my institutional's IRB. Children undergoing head CT in the emergency department often require sedation in order to maximize motion control as well as ensure adequate imaging is obtained. This study looked at children undergoing head CT for minor blunt head trauma and found that 3% required pharmacological sedation. 94% of patients had successful sedation on the first attempt, which included often 2 doses of a single sedative medication. Prior to November of 2017, our hospital system had conventional single source CT scanners with an image acquisition time of 12 seconds. However, in November of 2017, we installed 2 new scanners that use dual source, dual energy technology that decreased the image acquisition time to 1 to 3 seconds. This study looked at the use of these faster technologies for CT scanners and found that the rapid scanning techniques often negate the need for sedation in children. We performed a retrospective chart review of children 0 to 18 years of age undergoing CT and compared 2 years prior to the new CT versus 2 years after the new CT was installed. Patients were enrolled at 2 pediatric emergency departments within a single hospital system in a large metropolitan area. Patients undergoing head CT with and or without contrast were included. Patients who did or did not need sedation were included, and the sedatives analyzed included chloral hydrate, dexmedetomidine, etomidate, fentanyl, ketamine, methotrexate, midazolam, pentobarbital, and propofol. We excluded patients if they were undergoing multiple imaging studies or required other procedures such as spinal tap in the emergency department. 15,175 patients were included for analysis. 7,412 of those prior to installation of the new CT scanner, compared with 7,763 patients after the new CT scanner. In the group prior to the installation of the new CT scanner, 8% required a sedative compared to 7% afterwards. This table shows the demographics of the patients included in our study. As you can see, there was a significant decrease in patients who required sedation after installation of the new CT scanner. Interestingly, the length of stay increased after installation of the new CT scanner, but the reason for this is unknown. These are the demographics of the patients who required sedation. Predictably, patients who required sedation were younger and had longer length of stays. The 2 hospitals in our hospital system included in this study had different percentiles of patients who required sedation, and the percentile of patients who were discharged home was different in the sedated versus not sedated group. This graph shows the sedatives administered, and as you can see, midazolam was the most commonly administered sedative both pre and post installation of the new CT. These graphs show the number of sedative doses as well as unique sedatives used. In the top left corner, you can see that the majority of patients only required 1 sedative dose, both pre and post installation of the new CT. However, after installation of the new CT, it was less likely to require multiple doses, and 0 required more than 4 doses of sedatives. In the lower right corner, you will see the graph that shows the unique sedatives given. And as you can see, most patients only received 1 sedative, both pre and post. These were the sedatives that were administered to our patients, midazolam being the most common in both pre and post. However, its use as a single agent did increase, while the use of propofol alone or in combination with midazolam decreased significantly. Therefore, less patients required deep sedation after installation of the faster CT scanner. This table shows the route of administration of sedatives. Midazolam was most commonly administered nasally, followed by IV and oral or G-tube route. We concluded that fewer patients required sedation using the newer, faster CT scanner. However, this finding is likely not clinically relevant given the 8 versus 7% of patients requiring sedation. Fewer patients required deep sedation with either propofol or in combination with midazolam after installation of the new, faster CT scanner. And we believe this finding is not only statistically relevant, but clinically relevant as well. For future directions, we believe that there is a need for more standardized approach to sedation for head CT. If we were able to determine ahead of time which patients would require sedation or deep sedation, it would allow for less failed CTs and less failed minimal sedations. It would also decrease the length of stay for most patients in the emergency department undergoing head CT. This also points towards a need for standardized sedative choice and dosing recommendations for children undergoing head CT in the emergency department. Thank you for your attention, and I'd be happy to answer any questions that you have.
Hi, my name is Taylor McCormick. I'm an assistant professor of emergency medicine at Denver Health and the University of Colorado School of Medicine, and it's my pleasure to present the abstract entitled Defining Severe Injury in Pediatric Trauma. I have no financial disclosures. This work was supported by an institutional pilot grant from Denver Health and Hospital Authority to me. A little background on why we performed this study. We know that severely injured children have better outcomes when they're transported to trauma centers with pediatric capabilities. Field trauma triage aims to identify severely injured patients in the pre-hospital setting to guide these destination decisions. But evaluation of trauma triage processes requires a clear definition of severe injury, which is not well established. In response to limitations of the widely used injury severity score, a consensus-based definition of trauma center need has been proposed but not validated in children. And the goal of this study was to determine the agreement between ISS greater than 15 and the consensus-based definition with a focus on discordant cases. These are the components of the consensus-based definition that was proposed by Lerner et al. In 2014. As you can see, it's mostly intervention-based, receiving greater than 10 cc's per kilo of blood products, advanced airway management, thoracotomy, pericardiocentesis, emergency cesarean delivery, intracranial pressure monitoring, interventional radiology intervention, or non-orthopedic surgery. All meet the definition with the corresponding time stamps on the right. Additionally, if you're admitted for a spinal cord injury or would have required one of the above procedures but died in the ED or as an inpatient, you would meet the definition. So we performed a structured chart review of consecutive trauma patients at an urban trauma center in Denver, Colorado. All trauma patients less than 15 years of age transported by the Denver Health Paramedic Division from the field to Denver Health Medical Center between 2011 and 2018 were included. Trained abstractors blinded to the study objective reviewed hospital, ED, and inpatient records to determine whether the consensus-based definition criteria were met, and ISS was obtained from the trauma registry. Agreement was calculated using Cohen's kappa, and descriptions of discordant cases provided. Of the 4,503 injured patients transported to Denver Health by the paramedic division during the study period, 347 or 7.7% met trauma registry criteria and were included for analysis. 50 of those, or 14.4%, had an ISS greater than 15, and 51 or 14.5% met the consensus-based definition. 33 met both. There was moderate agreement between ISS greater than 15 and the consensus-based definition, with a kappa of 0.59 and the confidence intervals shown. Of the 17 cases with an ISS greater than 15 that did not meet the consensus-based definition, 6 of the 17 were due to multi-system non-accidental trauma, and 0 of the 17 required intervention during their hospital stay. Of the 18 cases with an ISS less than or equal to 15 that did meet the consensus-based definition, 8 of the 18 underwent non-orthopedic surgical intervention for single system injuries, and 7 of 18 were intubated for head injury. So our findings are similar to those of Willenbring et al. In 2016, who performed a similar validation in adults. Our study is limited by small numbers, the retrospective design, and the limitations of chart review. When deciding whether to use ISS greater than 15 or the consensus-based definition, I think it's important to consider that the consensus-based definition requires pretty extensive chart review, whereas ISS is more readily available, particularly if it's already being calculated for trauma registry purposes. I think it should also be considered whether or not these definitions should be combined and whether both definitions might miss patients that would benefit from pediatric trauma center resources. And finally, I think it's also important to keep in mind that pediatric trauma center resources extend beyond interventions for both patients and families. In conclusion, severe injury in pediatric trauma patients is rare. Agreement between ISS greater than 15 and the consensus-based definition was moderate, and the consensus-based definition better identified children who are likely to benefit from pediatric trauma center resources compared with ISS greater than 15. Thank you.